the QA. So I invite all the speakers from this morning to have a seat here. Why don't you leave that one to pass around? Okay. I'm going to kick it off with the first question. Right there's a seat right here. I have a question for Dr. Cheng. So this is one that I actually get a lot in the clinic. Many of you participate in testing 23andMe or other types of hereditary tests looking for ancestry. And I get a question is, does that really give me information about cancer risk that's accurate, and in particular the BRCA genes and inheritance? So Heather, do you have thoughts about if somebody does those kind of tests, does that obviate the need for doing the kind of germline testing you were talking about?
Yeah, I think it's a good question. I think there's a lot of, I would just make the distinction between what I consider more recreational testing, which is more just for interest. Those tests may sometimes give you some indication. I think 23andMe does have a small subset of 3 major mutations that it reports, but it's not designed to do that. And so I worry a lot about hinging too much or putting too much confidence in the fact that that's the end of the story. That may give you an indication that you need to follow up, and I would really, really strongly encourage anyone who might get a hint of that to follow up with an actual genetic counselor and really go through the meaning of that test. And similarly, a negative result with a strong family history of a test like that is not sufficient. It absolutely is not sufficient. So it's really important to just make a distinction between sort of more for fun tests and then a medical test under supervision of experts like genetic counselors and medical geneticists and so forth. So
great. We're going to have short, succinct answers because you guys have a lot of great questions. And what I'm going to try to do is synthesize the questions we're getting recurrently. But if your question wasn't answered, grab these people during the coffee break and curbside them one-on-one. So a lot of dietary questions, actually. So Marion, your first question was what to eat. So a specific question here is what should you eat? Related, is the lower risk of prostate cancer in Asian Americans, or just, I guess, Asians, maybe not Asian Americans, thought to be related to diet versus genetics? But really the key is kind of what to eat. Is chocolate good or bad? Fat in the diet, carbs, et cetera. So you get the gist.
So those are all great questions. So there is evidence that prostate cancer may be lower in people of Asian descent compared to other groups. Some of that changes when Asians move to the United States. So that suggests that there is some kind of diet, exercise, lifestyle component to the risk. And the traditional Asian diet is lower in meat, especially red meat, and higher in vegetables. So those are very positive aspects of that particular dietary pattern. I think what we are discovering overall, and I've talked about this in past years, that's not so much any one particular good food, bad food, or what you eat on one particular day, but what is your overall dietary pattern? What's a healthy dietary pattern day in and day out? And a healthy dietary pattern is one that includes small amounts of animal protein. So, not the big 16-ounce steak. That's okay once in a while if it's your birthday, anniversary, some special occasion, but you don't want to be eating that, 3 or 4 times a week. So plenty of fruits and vegetables, small amounts of animal protein, and it should be lean protein, so cut the fat off, small amounts of low-fat dairy, and whole grains. So when you hear about carbohydrates and grains, not all carbohydrates are created equal. The ones that are white, so white flour, white bread, white rice, those should be once-in-a-while foods, but whole grains, and I mean really whole grains, those are great for you. They make your gut bacteria happy. They provide a good dose of fiber and so forth. So, and minimal alcohol.
Related question, what about fasting? Is there any evidence that fasting for 2 or 3 days has any benefit, pro or con?
We don't really have enough evidence yet on whether fasting will improve either prostate cancer risk or progression.
Okay. Dr. Etzioni, what group do you place mixed race in terms of risk, right? So, I don't know, you may even want to discuss the issues of kind of categorization of Black, African American, other races. I don't know if you want to address that.
I can give you a very short answer to that question and say that that really hasn't been studied. And I don't think that, again, we have to create the data to be able to study that.
Okay. There's a question about intervention. We heard a lot about the exercise interventions for advanced disease, but the question is, I think, Jonathan, what about, can you maybe explain a little bit more the interventions either prior to a cancer diagnosis or the active surveillance? Maybe bring that across again, what the studies or interventions are for either newly diagnosed patients to prevent progression.
Right, so what we have is happens to be right here, the prostate active lifestyle studies. So for those men on active surveillance who are overweight or obese, it's a 6-month intervention. We time it with your upcoming next biopsy, because on active surveillance, you do surveillance biopsies. Actually, one of our study coordinators is here right now, Alexandria, helping out today. So the intervention, the dietary intervention is based on what's called the Diabetes Prevention Program, and it's a lot of what Marion was just talking about. It's basically helping give you the tools to eat smarter, make better decisions, and make it for a life for you can do for the rest of your life. This intervention has been shown to help people lose 7% of their body weight over 6 months and to keep that off 10 years later. So a lot of the fad diets, you can lose weight real quick, but it's tough to keep that up. And so this is helping you really get the tools to make better decisions and keep it up. And the exercise component is supervised at the exercise center, but it's working on those 30 minutes, 5 days a week of moderate exercise with some resistance training. So you can't be on metformin or insulin to participate, because we're looking specifically at that as one of our markers. But if you're interested, you can be either newly diagnosed or somewhere along the lines on active surveillance. We'd love to have you grab one of the flyers, talk to myself or Alexandria or Dr. Neuhouser later on this afternoon.
Great. For ED therapy, erectile dysfunction therapy, the question is, are these interventions covered by insurance? Pumps, injections, et cetera?
Short answer is sometimes. It depends on your provider or your insurer. Often we see the surgical therapies are covered, but sometimes they are not. And the vacuum devices are a few $100 and usually not covered, I believe. And then the coverage of the medications and the injectables, again, varies by provider or by insurer.
Yeah, Medicare used to cover the pump, and they stopped about a year ago, unfortunately. I'll just say on the order of payers, that's one of the goals that we have for these intervention studies. Is that if you have a heart attack, you get a prescription for cardiac rehab, where you go and you work on your diet, you meet with a nutritionist, you work on an exercise program. Why don't we have that for a cancer diagnosis? They need the data. A lot of those studies that I was showing you in exercise were done in Australia, where everybody gets it. Given what you get this covered to go and get these type of interventions when you have the diagnosis. So we hope with these data that we can get the payer to say, yes, here's your cancer diagnosis, here's your prescription to go help you get the tools you need to lose weight and improve your life. So,
Jonathan, if moderate exercise is good, yeah, is twice as much twice as good?
I was told there'd be no math, so. I think what you need to do is be safe. So if you are not exercising now and you're going to take this as kind of an incentive to go and join a gym, get the introductory trainer, pay a little extra money to get that first steps, because you can easily hurt yourself, and then we've done no good. So I think it's we can't do what we did when we were 20, at our ages and older. So be safe. Certainly more is probably better, but more so much that you hurt yourself is not.
So Marion and Jonathan, which is better, diet or exercise?
One of the reasons that the PAL study has both is that both are important. And Dr. Wright and I are also working on another grant proposal, which we hope to get funded soon, and that will be for men on ADT who are also receiving radiotherapy. And we're hoping that if we can get men into an intervention while they're just beginning therapies, it can help prevent the weight gain that he showed in those photographs. Some of the studies that have been done in women by our collaborator, Dr. Ann McTiernan, over in our prevention center, showed that neither one alone was as effective as both together. So it's both.
Heather, oh, go ahead. Heather, can you say anything about concerns of genetic testing and insurability for their healthcare or maybe
Yeah,
life insurance, et
That's a
cetera?
common question I get asked, and it's absolutely an important one. So there are currently federal laws, the Genetic Information, I think GINA, preventing workplace and health insurance discrimination. Life insurance is a little bit different, although I will say that most life insurers can, take many factors into account, and they usually ask for a family history, and they ask about diet and lifestyle, and they take all of that into account. And so if that is something of concern to you or your family members, definitely worth talking with a genetic counselor before. But with respect to insurance and typically not so much. But if there is a concern, that's when it's helpful to talk with the genetic counselor more in detail.
Great. So Jonathan and Neil, both. Question is, after prostate cancer treatment, does incontinence increase? And a more maybe specific question around nocturia related to radiation, and is that known to increase, and what kind of therapies might you consider?
Sure. I mean, every treatment has side effects, and certainly radiation can cause some effects on the tissue nearby the prostate, which is the bladder and the rectum. So it certainly does increase urinary frequency and can increase nocturia. Nocturia is having to urinate at night. There are options, medical options for that, and I would discuss those with your provider, your urologist, your radiation oncologist, or your primary care provider. So there are also a lot of things we can do around nocturia with just lifestyle modifications. And so if we can avoid doing a medication, we typically would prefer to do that. So that's another thing we can talk to you about. Dietary irritants, which can make the bladder more irritable, timing of when you do fluids at night, those kind of things can be helpful. Interestingly, one thing that's not appreciated as much is the relationship between sleep apnea and getting up at night. Obesity is one of the leading factors of sleep apnea, where you basically stop breathing at night, so if you're a really, really heavy snorer, that might be a sign. And there have been studies that have shown that people that get a CPAP, which is the treatment for sleep apnea, their nocturia, nighttime urinary episodes, go dramatically down. And there's actually physiologic reasons why that happens. So a lot of people think, oh, I'm just waking up because I got to go urinate. Well, no, you're because of the breathing thing. So it's if you think you have sleep apnea, get evaluated. It can help your nocturia.
So one last question here is there any evidence that bicalutamide, which is an androgen receptor antagonist, is equivalent in terms of these side effects of androgen deprivation therapy to testosterone suppression, i.e. ADT? Do you want to take that, Jonathan? Or
Sure. So, bicalutamide is an androgen receptor antagonist. So as opposed to, say, Lupron or Zoladex, which is an LHRH agonist, they do have slightly different side effects. The bicalutamide type medications can have more breast tenderness, gynecomastia, especially at higher doses. There can be better preservation of erectile function, because rather than pushing your testosterone down, there's some preservation of it. However, it is clear from studies that it is inferior in cancer control alone compared to the androgen deprivation therapy of Lupron, Zoladex, or one of those LHRH agonists.
Great. So we're out of time here. We're going to take a 15-minute coffee break. If your question wasn't answered or you just didn't have time to put the card in, grab